Okay, this webinar discusses tennis elbow, its causes, its treatments, and the search for etiology in particular. But let's clear up some terminology first. Typically, the term lateral epicondylitis is used for this rather than the old term of tennis elbow because it sounds more technical, but it's completely and utterly incorrect in most respects, if not all respects. First off, the epicondyle is not affected, the tendon is. So why name it epicondylitis when it's not the bone, and it's most cases it's not even inflamed. Most of the conditions we see are actually tendinoses rather than tendinitises, and in fact tendinitises are fairly rare. So the terminology lateral epicondylitis is completely wrong in the form of it being a problem with the bone, and almost always wrong in concerning it being inflamed. So if we will talk about diagnosing and staging tennis elbow. As I say, I'll call it either tennis elbow, or its proper name should be common extensor tendinosis. And that is a subset of common extensor tendinopathy, to which belongs tendinitis as well. But common extensor tendinitis is a bit of a mouthful, or tendinosis is a bit of a mouthful to keep saying, so I'll probably use the terms interchangeably: common extensor tendinosis or tennis elbow. I also don't want to give the impression that tennis elbow means a tendinosis. It is also used as tendinitis. It's a historical term for it, and I understand that it isn't particularly accurate in that most cases of common extensor tendinopathy aren't caused by tennis. It's just that one seemed to be the one that was most popularly used. And God knows how many years ago, but ever since I was a student anyway. So at least the last 300 or 400 years. Conditions have a cause, and it's just intellectually lazy to blame everything on overuse because the person you're dealing with uses his hand at work. If the amount of usage it's getting is such that it might cause an inflammatory condition, it's going to be unfamiliar and it's going to be extreme. Typically, it would be somebody painting a house and spent all day doing it. The person who works with his hands all day doing carpentry or something similar and has been doing it for years, the tendon tends to get stronger, not weaker. So when it does break down, it's because something's happened either externally in the environment or internally within the body. And this is where we're going to go with this webinar, is looking for internal causes. But it is lazy to blame everything on overuse syndrome. And the problem with it is that's as far as you can go. You can't investigate any further once you label it as overuse. Are they using it? Yes. Is it overuse? Well, I think so. Probably they don't. And then having said that, you've only got one treatment left. That's avoidance or modification of work activities. And it may not be that at all. So it's actually a very irresponsible diagnosis to use, and it should be avoided at all times. If we see somebody with a true tendinitis, and we'll talk about differentiating these as we go into this webinar, and there isn't an obvious cause for it, that is, they painted the house over a couple of days, they played tennis for the first time in God knows how long. If there isn't a good reason for that tendinitis, then your mind really should be turning towards medical conditions that do cause tendinitis. Systemic arthropathy, diabetes, a whole bunch of stuff does this. So even a tendinitis isn't necessarily benign, and it isn't necessarily something that you really want to be playing with too much. So everything I'm going to say about etiology of tendinopathy applies to joint problems, and it also applies to every other part of the body, but there are different amounts of, or different ratios of influences. In the upper limb, we're going to find that it's mostly neurophysiological. In the lower limb, it will be mostly mechanical forces. But the principle remains the same, the details change area to area. So that's where we're going. I hope you enjoy it, and I hope that you get something from it. And Okay, so this is this webinar's quiz. Can you figure out what's wrong with these eyes and faces? Good luck. Earl Petman came up with a very nice phrase that sums it up. There are victims and criminals, and we tend to beat up the victim. Look for the criminal. This slide describes the overall process for the assessment of the presenting complaint, the primary diagnosis, and for the etiology of the presented diagnosis, the secondary diagnosis. It follows that you may have to look for tertiary and quaternary diagnoses, but at some point you have to stop and say, I have no idea what is causing this. First, make the diagnosis. I know this sounds obvious, but it is a lot more common than not to find PTs mixing up the diagnostic exam with the etiological exam. How can you possibly know what is the cause of something until you know what that something is? The combination of both as an assessment just produces more information, a great deal of which is noise that blocks the signal. Including the diagnosis must be the stage of the condition. In this case, is the tendon inflamed or degenerate? For etiological purposes, we're almost invariably interested in degeneration of the tendon, tendinosis, rather than tendinitis. By the way, I'm sorry if I mix up English, Canadian English, and American English. Most of the time I have no longer any idea of what language I'm using. But having a full diagnosis, we should now consider etiology. Is there an obvious cause? And if there is, did it cause inflammation? If not, the cause is less obvious than you thought. If you have a causeless tendinitis, then you have to consider medical conditions such as systemic arthropathies or diabetes. If you find a tendinosis, then ignore the trigger and consider the factors that could cause the degeneration. These factors include output weakness of the muscle or structural weakness of the tendon, or internal overuse by abnormal length-tension relationships, or to my mind, more likely, negative feedback from hypomobile joints. Then look for the appropriate causes and treat them. Finally, make sure the treatment has worked in the mid and long term by follow-up either by phone or by having the patient attend, if necessary for free, as this is a learning experience for you after all. Whether or not there is inflammation present plays a very real role in considering etiology. Tendinitis is not very common in general practice and is generally caused by trauma, serious unfamiliar overuse, and medical conditions such as reactive arthritis, rheumatoid arthritis, ankylosing spondylitis, gout, diabetes, and other systemic conditions. Often systemic disease tendinitis is called enthesitis to differentiate it from trauma and overuse, but they are pretty much the same pathology, inflammation. There is supposition that tendinitis can convert into tendinosis over time, and given the healing process, it seems probable. But there are certainly enough cases that have no history of tendinitis to suggest that this is the only pathway or even a common pathway to tendinosis. Tendinosis seems to develop over time, with it becoming symptomatic at some definite point in its lifetime. The slide shows the main clinical differences experience suggests are seen between the two related but separate conditions. The degrees of pain are exponentially different between the two. The difference in tenderness is night and day, with it having to be aggressively sought with tendinosis, but the gentleness of touch is being able to produce a severe reaction in tendinitis. The response to stretching and isometric contraction tests is also completely different, with the gentleness of contractions causing severe pain and weakness, and pretty much the same response to stretching, but with spasm with tendinitis. Functional loss is obligate in tendinitis. They simply cannot use the hand. Tendinosis usually has no obvious cause, but does have a trigger. This may be put down to the type of work the patient does, but something has changed, and if the change is not in the external environment, then it must be in the internal, and that is what this webinar is about, finding those changes. This is another version of the previous slide in list form. It may be clearer for some of you, while the other one is better for others. Anyway, it doesn't hurt to repeat this. I'll leave it running for a moment. The three main methods of clinical reasoning for diagnosis used certainly by us is pattern recognition, hypothetic deduction, or more correctly, hypothetic abduction, and modification of the latter as script-focused hypothetic abduction. I should make a statement for your benefit. The final method was developed by me, so you should feel free to be as skeptical of this as you should be of all types, but mine has not stood the test of time or usage that others have. It does have the advantage, though, of keeping things much simpler. Pattern recognition is the method used by experts in a particular condition. Expertise doesn't come just with time, it comes with quality time. Experience where analysis involving reflection and self-criticisms looks at both successes and, more importantly, failures over a large number of cases. Expertise can't come with time if awareness of weaknesses is not present. This allows the expert to recognize a problem very quickly, sometimes in seconds, and almost always be right. The condition is almost recognized immediately by the location, in this case of the pain at the lateral elbow, and confirmed with a history of pain on the use of the hand, followed by palpation of the tendon. Because tennis elbow is so simple to recognize, the process is what most moderately experienced therapists do. But the expert manual therapist is different for three main reasons. First, they do not consciously seek more information than they need. Second, they can deal with more conditions of greater complexity and variability. And third, it has been shown that they are constantly considering alternative diagnoses during the process. First, let's clear up a little terminology. I've used the word abduction alongside the word deduction in this slide. Clearly, abduction is not used as it is in anatomy, although the origin of both is the same, that is, to take away from. In this case, it's taken an inference away from the facts. The word inference can also be used to replace abduction, but abduction is a little bit more widely used, so we'll use it here. Although actually inference is probably the better term. The biggest logical difference between deduction and abduction is that deduction is always giving the correct conclusion. You can read diagnosis in this case, if the premises are true, whereas all other methods of reasoning, including abduction, do not afford the absolutely correct answer. The biggest practical difference between them is that deduction rarely works in the clinical world or in the real world, come to that, not least because you can't be sure of the premises. Abductive reasoning involves making a best fit, and like all clinical diagnosis is provisional on a number of things. If you imagine the disease as a box that contains all the things that make that disease it, then the signs, symptoms, predisposition, everything else should also fit into that box. And that's what I mean by making a best fit. On a practical level, again, the biggest problem with hypothetic deduction or abduction is that it is almost always involves the accumulation of too much information. Items such as family history, occupation, leisure activities, imaging, and so on. None of these things really has anything to do with making the initial clinical diagnosis, but are relevant to etiology. So you can get overwhelmed with the information, then grab and hold on to the first bit of information that makes sense. This is anchoring. Also, the information that isn't relevant to the diagnosis may also frame you and give you a framing bias. Let's look at the essential illness script, or EIS, for common extensive tendinopathy. As you can see, it contains 4 features that pretty much define the average presentation of tendinopathy rather, and I think you'd find it difficult to see what else this could be. There are 1 or 2 conditions with atypical variants that might mimic 1 or 2 of these features, but as a group, they are the best fit for the condition, and it is a good example of abductive reasoning, as are all good essential illness scripts. Whether the tendinopathy is a tendinitis or tendinosis isn't addressed with this EIS, but differentiating them follows the diagnosis and can be seen on the next slide. Remember that for the vast majority of cases where a hidden etiology is to be sought, the diagnosis will be tendinosis. Almost all degenerate tendinopathies are tendinoses and are produced over a long period. That is, there is not a specific event that causes them, with the exception of tendinitis converted into a tendinosis. The onset of tendinosis is not when the pain starts or the tendon snaps, but long before. But generally there is a trigger that causes the pain. If the trigger does not happen, then the tendinosis remains quiescent and the patient is unaware of its presence. This diagram is essentially a repeat of an earlier one showing the differences in the 2 types of tendinopathy. I'm leaving out tendon sheath problems from this slide because they are usually inflamed and not really part of this discussion.